Well, greetings everyone, and welcome to the EKG case for the week of September 10th, 2012. My name's Amal Mattu, and this week we've got a really fun case for you. But actually, before we get into it, there's a couple of comments that I just want to make. First of all, the case that we started with last week from September 3rd that was sent in by Dr. Donald Brannigan. My thanks once again to Dr. Brannigan for sharing that case. And I had listed his blog site, and he just changed the blog site. So if you're interested in checking out some of the educational tidbits and the cases that he's been sharing with the Twitter world and with the rest of the world, check out this new website, underneathem.com. All right, let's move forward. And the other introductory point that I want to make is that this is the first case of our second year doing these EKG cases of the week. Can't believe it, but we've actually been through 52 EKG cases of the week, and now we're starting our second year. Hopefully, for those of you that have been following along since September of 2011, hope you've picked up an awful lot of pearls and pitfalls and learned a lot of electrocardiography along the way. And I really appreciate all of those people who have sent in interesting cases and emailed questions and comments, and it's really fun to get all of that feedback. Speaking of people sending in cases, this week's case we're going to move on to sent in by Dr. Pratibha Shenoy, who lives out in Perth, Australia, and she sent in a somewhat unusual case. And since this is kind of a celebratory type of week, since this is our birthday week, we're going to do kind of a zebra case. So I'll tell you right up front, this is not the kind of case that you're going to see every day or every month or every year. You might pick this up once or twice during your career, but I'm going to tell you up front that if you pick up this EKG case anytime in your career, you are an absolute superstar. You're a rock star. You're going to have paparazzi, EKG paparazzi following you around with the calipers and everything else. So, if you pick up this case, then, man, that's a great case. You are going to really rattle those cardiologists. They're going to think, oh my God, this person really knows electrocardiography. We better not challenge him or her on anything he says. So that's the value of knowing about this particular case. Plus, for those people that have become EKG nerds like me, this is kind of a fun case. All right, so here's the typical history. I don't know the exact history with the case that Dr. Shenoy sent in, but this would be a typical scenario. And actually, I should mention, my wife is an internist. She's an internal medicine physician, and she's got a couple of patients in her practice who have this condition, and this is the typical presenting symptom that they arrive in her office with. And so I'm using one of her patients as the history. But here's the 12-lead EKG that Dr. Shenoy sent in. So we'll briefly go through this. I don't want to focus on the rhythm because this is kind of a wavy baseline, and the rhythm is a little bit difficult. I don't know whether this is slow atrial fibrillation. It looks like there's a lot of wavy beats in there, or is this an atrial tachycardia and all those waves or beats? Or maybe there are some places that clearly look like there's P waves up there. So maybe this is sinus rhythm with a really long first degree AV block. I'm not really sure, but let's not focus too much on the rhythm. I want to focus your attention on a couple of other things. First of all, there's a bit of a rightward axis, okay? Maybe not a full right axis deviation, but there's a rightward axis, which is important. We'll talk a little bit more about that. And also, there's an incomplete right bundle branch block pattern. There's that RSR prime pattern in V1. I call it incomplete right bundle because it's not a full 120 milliseconds wide. The QRS is a little bit too narrow to call it a right bundle, so we call it an incomplete right bundle branch block pattern. And the main, almost pathognomonic finding on this 12-lead EKG for this diagnosis is, if you take a look in the inferior leads, you'll notice there's these little notches right at the end of the QRS complex. And those notches are almost pathognomonic for the condition that we're talking about. Those notches are oftentimes referred to as a crochetage pattern, and I believe that's a French word, and I don't know if I'm pronouncing it correctly. If there's any people out there who speak French and have a literal translation for the word and can tell me how to pronounce it properly, please email me. But I assume that the translation refers to notching, because that's what we're seeing. There was notching pattern in the inferior leads And that means that this patient has an atrial septal defect. Now, I don't want to go too far into detail into talking about ASD. This is often diagnosed and corrected in childhood, but there's a not insignificant number of patients for whom the diagnosis is not made in childhood. They go on into adulthood. They do pretty well in their 20s and 30s, but then by the time they get to their 40s and 50s, that's when the symptoms typically start developing. The most common symptom probably is dyspnea on exertion, which is what my wife's patient had. CHF may develop, palpitations, syncope, pulmonary hypertension at later stages can develop, and that's going to produce right ventricular hypertrophy, right heart failure. Atrial tachydysrhythmias can occur and stroke. So there's a bunch of bad symptoms that are going to develop. And the strange thing is that patients do pretty well in their 20s and 30s, and then 40s, 50s, that's when symptoms really start hitting. So let's talk about the EKG. There's a few things that are very sensitive and something that's very specific. So first degree AV block, very common. And I suggested that this patient may have a first degree AV block. Literally what's happening is that with the ASD, the atrium is stretching. So literally the sinus node is getting further and further away from the AV node. So it takes longer for that impulse to conduct down to the AV node. That produces a first degree AV block, a long PR. Atrial dysrhythmia, as we talked about, incomplete right bundle. This patient has it, and it's very, very common. In fact, I was reading in some places which said, practically speaking, if you don't see at least an incomplete right bundle, then it's not an ASD. So an incomplete right bundle is very common. Again, at later stages, you can get full-blown right axis deviation. This patient has a right-ish axis, but not a full-blown right axis deviation. And especially once pulmonary hypertension develops, they'll have that rightward axis. And then the crochetage or notching pattern in the inferior leads, I vaguely remember hearing something about that years and years ago. Turns out that that's actually very specific. In fact, here's an article from Journal of American College of Cardiology, which said that this notching pattern in the three inferior leads is 92% specific for ASD. So that's a really important point. Incomplete right bundle is very sensitive. The crochetage pattern is very, very, very specific. So if you see that pattern, then you're looking at a patient with an ASD. So on this 12-lead EKG, we'll go back to this once again. There's the incomplete right bundle, which is extremely sensitive, and there's the notching pattern. It almost looks like hypothermia J waves, doesn't it? Although hypothermia J waves usually show up first in the lateral leads, and this patient doesn't have anything out there laterally. It's just inferior leads. And then the other things that can show up as well are the rightward axis and also the first degree AV block. And this patient's got a bunch of interesting things. So like I said, this is just a fun case since we're starting off our second year. You might not see this type of thing for years and years, but if you see it, you pick it up, you look like an absolute superstar. And, well, hopefully this was kind of a fun case for you. And next week we'll get back to some things that are a little bit more common. So once again, thanks to everybody who's kept up with these EKGs for the past year, and I'm looking forward to having a great second year. If you've got some great cases, send them in to me. That's the reason I post my email on the first slide. So take care, everyone, and I will talk to you next week.